This week, we're going to cover thyroid disorders. Thyroid-related problems are an extremely common presentation in clinical practice, as well as in questions for the MRCGP AKT. And like many other endocrine systems, has a negative feedback mechanism operating behind it, with the stimulating hormone TRH, or thyrotropin-releasing hormone, encouraging the release of thyroid-stimulating hormone TSH to prompt the production of triiodothyronine and thyroxine, T3 and T4. The most common thyroid function test you'll find in most patients will include TSH and T4 values. In hypothyroidism, there is a reduction in circulating T3 and T4, and is classified usually as primary, where the issue is with the thyroid gland itself, or secondary, such as post-surgical removal of the thyroid gland or congenital dysfunction, which is quite rare. The most common causes include Hashimoto's thyroiditis, the most common cause globally, which is autoimmune and is found more common in women. This will have a positive anti-thyroid peroxidase, a TPO, and a thyroglobulin antibody, TG, as well as a non-tender goiter. Another cause is post-thyroidectomy or radioiodine treatment. Certain drugs can cause it, such as lithium, amiodarone, and carbimazole. Iodine deficiency is also quite common, with subacute thyroiditis or de Quervain's thyroiditis presenting usually as hyperthyroidism in a post-viral state with a painful goiter and a raised ESR, before leading on to a hypothyroid state months later before returning to normal. Often these patients have a reduced iodine uptake in their thyroid scintigraphy. NICE recommend a lower levothyroxine or T4 replacement in elderly population, as well as those with cardiac disease, but otherwise, most patients are started on 50 micrograms daily, with a review of thyroid status checked 3 or 4 months later. Pregnancy also increases the demand upon the thyroid, and thus doses are often transiently higher due to the demands of pregnancy. There is some suggestion that levothyroxine can cause a higher risk of osteoporosis, and care must be given in patients with AF or angina-like symptoms. Common symptoms of hypothyroid states include lethargy, tiredness and somnolence, cold intolerance, dry skin and a loss of hair in the eyebrows, constipation, and menorrhagia. What about hyperthyroidism? Let's start with Graves' disease, which is the most common cause globally of hyperthyroidism. Graves' disease itself presents the specific clinical signs that are often examined in the MRCGP AKT. These include ocular signs such as exophthalmos and ophthalmoplegia, as well as cutaneous signs as pretibial myxedema and thyroid acropathy and clubbing. It's worth familiarising yourself with images of these, just in case they're examined upon. Patients with Graves' disease often have a positive TPO and TSH receptor stimulating antibodies. In terms of treatment, Graves' disease, there are a couple of different options. Carbimazole, which can be started to reduce the thyroid status, but can cause agranulocytosis as a common side effect. Carbimazole and then subsequent thyroxine replacement can be considered in what is known as a block and replace strategy. Radioiodine is also considered to destroy parts of the thyroid gland. However, unfortunately pregnant patients and those with pre-existing eye disease are excluded from this, as it often worsens eye symptoms. Additionally, patients often need subsequent thyroid replacement. Surgery in a thyroidectomy is often considered in a goiter that's causing anatomical issues, and beta blockers are often used for symptomatic control. Propylthiouracil is also considered, is usually preferred in pregnant patients over carbimazole. Albeit Graves' disease is the most common cause of hyperthyroidism, it's worth being aware of other causes which include a toxic multinodular goiter, the initial phase of subacute or de Quervain's thyroiditis, the initial phase of postpartum thyroiditis, and amiodarone therapy. Common symptoms of hyperthyroidism, other than the ocular symptoms mentioned above, include anxiety and agitation, loss of weight, palpitations and arrhythmias, sweating, pretibial myxedema, and tremors. Finally, let's talk about interpreting thyroid function tests, where this is going to be the crux of many of the clinical questions in the AKT, and you'll need to be familiar with the common biochemical presentations. We've tried to simplify the common ones below, where a hyperthyroid state is classically a low TSH and a high T4. Primary hyperthyroid, such as that in Hashimoto's, is a high TSH and a low T4. Secondary hyperthyroid is a low TSH and a low T4. Sick euthyroid, which is commonly seen in acutely unwell patients, includes a low TSH and low T4. Subclinical hypothyroid usually includes a high TSH and a normal T4. This is common, particularly in primary care, and it's worth considering treatment in certain patients if TSH is above 10. And poor compliance with T4 is considered with high TSH and a normal T4. But it's worth considering the context of the exam question you're being asked. Well, that's that. I hope you enjoyed the video and have a greater understanding of the thyroid status, both low and high, and their subsequent management. Be sure to head over to our Facebook page and Instagram pages where there's loads of more great revision content for you. If you like the video, be sure to leave a thumbs up and leave a comment below. And be sure to subscribe so you don't miss any of the upcoming videos. But otherwise, I'll see you in the next video.